Gentlemen, welcome once again to another episode of the Think Clinical Podcast. My name is Hamza. Thank you so much. Today is another beautiful day, and we do appreciate all the support and everything you do for us. And today we are going to be talking about the new scalable healthcare practice. And if you imagine this in 2019, for instance, and you want to open a healthcare practice, you will probably need about $400,000 to $600,000 in startup capital. So you need to negotiate a lease. You probably need about 5 to 10 years from that. You need new equipment, your EMR setup, credentialing. That alone takes about 6 to 9 months, and then you hire a front desk person, you hire a billing person, even before you even start making any money, right? This is the old playbook, because as things evolved, you now look at the new generation where you have another doctor who is, let's say, an internist, who is launching a virtual first direct primary care practice in, let's say, 2023, and her startup cost is $40,000. She's generating revenue in week 1, and by month 18, she has 380 patients and a net margin of about 50. Same profession, completely different business model. So today, this is what we are going to be talking about. Welcome once again. If you haven't done so already, please remember to subscribe, like, and share, and let's move forward. So why is the old model broken? Because when you look at this, healthcare and technology is now fast growing segment in healthcare. And there's projected annual growth of about 8 to 9% if you go all the way into 2029. But the irony here is that most of that growth is projected outside of the traditional practice. Okay, so the old rules will tell you that, first of all, open a location, you get credential with as many payers as you can, see as many patients as you can, and the revenue will come. And for a while, it really did work. So you were having low overhead, you had very steady volume, and you had predictable reimbursement. So it worked for a while. Then the math changed, because now overhead as a percentage of collections is between 56 to about 60% in some situations, which is really high. So in some practices can be way higher. So when you are keeping only 40 cents on every dollar that you generate, you're not running a business. You are definitely running like a treadmill. And so the new model isn't about seeing more patients. It's about building a practice that generates more value per unit time. And this is important. Generating more value per unit time and per unit of cost, because if you are able to get these broken down correctly, you will be able to really project what you are getting out of it. What does this mean? Let me walk you through what I call the lean launch framework for modern healthcare practices. This is not a theory. It's what I have really seen work. So first of all, you need to validate before you build. And one of the most expensive mistakes that most especially physician-led practices do, is that they actually build the infrastructure before they have any form of validated demand. So before you go and sign a lease, before you start credentialing anybody, before you hire a billing person, you need to make sure that you have a clientele or a group that is willing to pay for the services that you are offering. You need to. This is not a polite interest, not people telling you, well, I think I will buy something like that just to be nice to you. They have to actually have the willingness to pay for it. Because I remember when I was in business school, one of the things that I was told is in entrepreneurship is that if you do not have people who are willing to pay, and the money, the word is pay, for whatever product or service you are pushing out, that you don't have a business. First of all, and it's a very expensive mistake. So we have, I wouldn't mention his name, but a doctor who has a sports physician practice in Atlanta, and he spent 3 months building his audience on LinkedIn and through a weekly newsletter before he opened his practice. And by the time he launched, he had a wait list of 120 patients. He never had a slow opening month. Validation is not a delay. Validation is a risk mitigation that you need to be very important. You need to pay attention to, and you have to be very intentional about. Then once you validate, the step 2 of this is virtual first, not physical. You go physical when you must. Again, you have to go virtual first. You go physical when you must. So here's the mindset shift that separates what we call a new generation of healthcare entrepreneurs from the old ones. physical space is a cost center until proven otherwise. So telehealth is not just a pandemic emergency anymore. Now people use it for a lot of follow-up care. People who have chronic disease management, a lot of them don't need to come in to see you physically. Behavioral health, nutrition, counseling, and dozens of other health lines. Patients want the convenience, and providers can deliver quality care through those digital platforms. The practices winning right now are launching virtual first and adding physical space when they really must, and it's not like a default setting for them at all times. So the difference in capital requirements is staggering. So if I was to start a virtual first, guess what my cost of a startup would be? Between 20,000 to 60,000, and you're good to go. Now traditional startups will start from 300,000 to 700,000. The capital difference either stays in your pocket or it gets deployed into growth. However you decide to do this, the second step after validating your idea is to go virtual first, and you go physical when you must. Now the third thing is that you have to niche down to scale up. The only way to do that in this modern era, and I've told a lot of healthcare entrepreneurs that I mentor and people that I sit on boards with, and I said, look, you want to do everything. In this era right now, the healthcare doesn't reward people who do everything. So you need to niche down. But again, it sounds counterintuitive for physicians trained to treat everyone. Business runs on differentiation, so you have to be able to appreciate that. And one of the fastest growing categories in healthcare practice right now is what I call condition-specific platforms. They are platforms that are based entirely around a single clinical problem. So it could be metabolic health, it could be perimenopause and menopause care, it could be men's health optimization, it could be long COVID recovery. When you own a niche, your marketing dramatically becomes very efficient. Your patient acquisition cost drops. Your clinical outcomes improve because your team does the same thing over and over and over again. And patients prefer other patients because people with the same conditions really do talk to each other. So the margins there for you is huge. And when you look at something like Midi Health, which is a virtual first menopause platform that scaled from over 100,000 patients without a single physical location, they didn't try to do everything. They became the best at one thing. And that's the model. So that's the third thing you need to look at. You need to look at how you niche down to scale up. The fourth thing is revenue diversification from day one, and you have to be very sure of where your streams are coming from. If you are going to depend on only insurance reimbursements from day one, that's not going to work for you. So you need to actually understand exactly what or where your revenue streams are going to come from. Make sure you have membership fees. People should pay $50 to $100 a month over a period of time. This is recurring predictable cash flow for you. Secondly, cash pay services. Don't turn all your services to cash pay services. Make sure you have all this in. And then group programs, corporate wellness contracts, digital courses. I could go on and on and on. Make sure your revenue diversification is from day one. And I'm not saying you need to do those on the time you open your clinic. You need to design your practice from beginning so that the insurance is just one of those streams. It's not the only one that comes, because as I said, and I've said this in previous episodes, the reimbursement rates in insurances are no longer the best, so they have caused a lot of contraction. And then the last thing I would like to talk about is, after you go through all these steps, is that the busy but broke trap. And I've spent a lot of episodes talking about this in different ways, and this is what I see destroying practices. You can always be fully booked. You can have a 6-week waiting list of patients but still be losing money. Volume without margin, that's what you are doing at that point. And when you do this math, for instance, let's say you are seeing 25 patients a day and your average reimbursement is $120 per visit. You are generating what, $3,000 before overhead, before malpractice, before your staff, before your compensation. So when you're looking at 60% overhead, your take home from that day is $1,200. If you divide that $1,200 by the 10-hour shift that you did, that's $120 an hour as a physician owner. You are going to make more money as an employee if this is the model you're running. This is less than it. The escape from this trap is not seeing more patients, it's seeing fewer patients at higher value, or building systems that generate revenue when you are not in the room. You have to be able to do that. So a blueprint for year one, if you are looking at starting this, your first 2 months, validate. And I'll keep saying this is one of the most expensive mistakes that we do. Build your audience, run patient discovery interviews, pre-sell memberships and packages if possible. Do this in your first 2 months. In the third and fourth months, launch lean. That's why I'm saying start virtual and only go physical when you must. In a shared clinical space, or just so that your margins are lower then. And then keep overhead under 10,000 per month until you have 100 patients. That's just the math. And then you go to week 5 to 8. Then you optimize. You track your cost per patient, your revenue per visit, your net margin weekly. Find 1 or 2 highest margin services and do more of those. And then when you look at month 9 to 12, you scale your systems that work. Hire for delegation, not redundancy. Invest in technology that multiplies your capacity. The practices that grow successfully are the ones that are disciplined to stay lean from phase 1. And you have to be able to look at that in this modern era. Healthcare entrepreneurship between 26 is not harder than it's more harder than it was. In many ways, the tools, technology, and models available today are better than anything that ever existed 5 years ago. What's harder is doing it the old way. The old way is expensive, it's slow, and it's increasingly precarious. So your new way, lean, virtual first, niche focused, diversified. Lean, virtual first, niche focused, diversified. And it's available to any clinician with the courage to think like an entrepreneur. You spent years becoming an expert in clinical administration. Now it's time to actually hone that skill into building a profitable, sustainable business in the long term. This has been another episode. Thank you so much. I will talk to you in our next episodes. Please remember to subscribe, like, and share.